Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
So the question Professor Murray asked is, should we be more cautious in the use of antipsychotics in schizophrenia? Yes, of course, we should be very cautious, as we should be with any medication. Medications are external substances. They intervene with the physiology of the human body. They have side effects. They have unpredictable side effects. That's not the case. This is something we should do with any class of medication. What's the case? The case is that our field, since many decades, is under a specific pressure from quasi-antipsychiatric circles. And these circles suggest, during the last few years, but yes, it started with Cunard in the 70s, that treatment with antipsychotics is not only not beneficial, but it worsens the long-term outcome of patients. And antipsychotic treatment should never be given. And the earlier it is given, the worse the outcome. And a softer version of this is that, okay, we should aggressively lower the dosage to the extent we aggressively try to discontinue medication to see whether these patients will do well. We can try to formulate 10 specific questions that we need to answer, and the answers do exist. They are more or less clear. We need to be balanced when we give a medication, antipsychotic, antibiotic, antihypertensive, whatever. We need to be balanced to see whether the benefits outweigh the possible side effects or the possible harm. And we need to see what is the overall outcome, because, you know, a specific drug might induce harm to the same direction the disease does, but the overall outcome could be much better. And this is an oxymoron, but still it exists. Should we avoid or give the least possible or even suboptimal subtherapeutic dosage of antipsychotics? Because by giving any dosage, we worsen the long-term outcome. This is the Van der Eyck conclusion. Well, the literature is not based on hard data, and there are two major studies from the 60s and 70s, the Rappaport of 1978 and the Schuller from 67, which were essentially, as you can see, negative studies. They utilized patients who did not do good on do well on under antipsychotics. So in the long term, yes, they were better off of them. So the literature does not support such an assumption that by giving antipsychotics you worsen the long-term outcome. The historical data suggests that with the first episode, something like 30% will spontaneously recover acutely, which means that 70% won't. And from these, half of them, from these 30%, half of them will keep their response and remission, which means that we have an 85% relapse rate. The introduction of antipsychotics at least doubled or tripled the better outcome. And more importantly, we cannot identify these patients that will do well without antipsychotics, and they are at the range of 15% maybe. the duration of untreated psychosis is not so important. So we need to wait and wait and wait. What we know is that the duration of untreated psychosis, that means if we delay treating patients, then we have a moderate, not impressive, but moderate adverse effect on the long-term outcome. So the sooner we start treating them, the better for their outcome. Even in the Wunderlich, the second Wunderlich study, the duration of untreated psychosis was the strongest predictor of a better outcome. So you see how the data come and fit together. Relapses, of course, are decremental to the overall outcomes. This comes with duration of untreated psychosis. We have maybe a 16% accumulated refractoriness by each subsequent episode. This is what we call the kindling model. And now the biggest question is there a brain volume loss in patients with schizophrenia? Is there? And what its causes? There are a number of studies suggesting that there is a neuropil loss, volume loss in schizophrenia, not a cell death, but a neuropil. Neuropil is the space occupied by dendrites, by synapses, etc., or the size of the neurons is smallest, but the number of neurons is not different. And this is present already at illness onset, but it also worsens with progression of the illness and affects mostly the left hemisphere and the superior temporal lobe. In summary, and this is what we need to have as a takeaway message, is that most of the literature we discuss is based on naturalistic studies. For example, the ESOP studies. Professor Murray suggested that maybe 10-15% do well of antipsychotics. Not sure, or the Soteria project. Not sure how we could interpret these findings when you do not really have many patients that are able to discontinue antipsychotics who are at a later stage of the disease where positive symptoms tend to diminish and negative symptoms and the neurocognitive deficit tend to evolve and be the most problematic. What the literature so far suggests is that we need to use antipsychotics continuously, both during the acute and the maintenance phase. When you do not do this, or you try to aggressively reduce the dosage, then you have a higher relapse rate. Now, I also have some reservations concerning the chart with risperidone Robin Murray showed. It's irrelevant whether you reduce the milligrams of the substance. What is important is whether you can reduce the occupancy. Now, if you reduce the occupancy below some specific level, then you don't have a therapeutic effect, or this is what we usually tend to say. Whether you reduce from 2 to 1 or from 4 to 3, it's not the problem. The problem is whether you can reduce the occupancy, because the occupancy leads to tardive dyskinesia or to other side effects. Antipsychotics are essentially also during the first episode. It's not wise to discontinue or aggressively reduce, as I said. And what is more important is that antipsychotic treatment seems to improve the long-term outcome, definitely, and to lower the overall mortality. This is a take-home message. The data we have, we can judge them, we can criticize them, we can whatever, but they point to a lower mortality rate. We don't have data suggesting that antipsychotics increase the mortality rate. We know that patients die younger in comparison, maybe 20 years younger in comparison to the general population, but this seems to be an inability of patients to catch up with the increase in life expectancy of the general population, not an externally induced reduction in their life expectancy. Thank you for your attention.